everyone, and welcome to the 9th annual CR Arthritis event. Today, I'm joined by Dr. Murray Barron, who is recently retired head of rheumatology at the Jewish Hospital at McGill University. Thank you for joining us today.
Pleasure to be here.
So let's start off with, can you tell us a little bit about yourself and how you're involved in rheumatology?
Well, I've been involved in rheumatology for many years. I'm a native of Montreal. I went to med school in Montreal. I trained in internal medicine in British Columbia, and I trained in rheumatology in Toronto. And I went back to work at the Jewish General Hospital in Montreal a long time ago, where I was the head of the division of rheumatology until last year. I've had an interest, particularly in scleroderma, which is what we're going to be talking about. Since I was in my training, actually. And about 20 years ago, I had really just been a clinician until that time. And about 20 years ago, I decided to change my career a little bit and get more involved in research, and particularly in scleroderma. And what we did was created a large group of rheumatologists across the country who could collect data on patients with this illness so that we can study large numbers, because it's a fairly rare disease, only about 300 per million population. So we created the Canadian Scleroderma Research Group with sites across the country and actually in Mexico City. And collected about data on 1,600 patients over the years and published many, many different publications about the disease with use of that information from that large database.
It sounds like an incredible network, an international network that you've created, like you said, to collect that data that is relatively rare so that we can really forward our understanding of these rare diseases.
Right. It was too difficult really for any one site to collect enough data to do a lot in a rare disease. So you need to collaborate with other people, which is exactly what we did. And Canada seemed like a good place for collaboration.
I love that. Yes, it is. And your keynote presentation at the CRA scientific meeting is titled New Outcome Measures for Systemic Sclerosis. Can you please share with us some of these new outcome measures, and how do you critically appraise an outcome measure to measure a disease or a condition?
Right. So I'm going to talk a little bit more than just about new measures, because we'll talk about measures in general.
I love that.
You know, if you can't measure something, you can't study it. Right. So you have to be able to quantitate what you find, right? And if you have a drug that you think will work for a certain disease, you have to be able to answer the question, well, how do I know if it's worked or not? I think we all agree that you can't just ask the doctor simply, you know, did this drug work, or ask the patient, did this drug work? You want to know how well it worked, how much better than a placebo, for example, that you use in a trial, how much better that it worked than the placebo, right? So you have to have what's called an outcome measure. So, for example, in rheumatoid arthritis, which is one of the more common, or the most common systemic rheumatic disease, really, the American College of Rheumatology approved many years ago outcome measures, which were sort of combined indices where you would, for example, a patient in the study would be examined by the physician, and every swollen joint would be counted and added up. So you'd have 20 swollen joints, and every tender joint would be added up. So maybe you have 30 tender joints. And you'd ask the patient, well, how do you feel now, more or less? We'll come to that a bit later. And you'd ask the doctor, well, how do you think your patient is doing now? And you put all those things together, and you have the American College of Rheumatology Response Index for rheumatoid arthritis. And you could use that in the trials, and the agencies that approve drugs for treatment in a disease accepted that and would look at those outcomes. And if you use the outcome properly and your drug was better than placebo, then the drug would often be approved for the treatment of rheumatoid arthritis. So that's why you need an outcome measure. In scleroderma, which is a rare multi-system disease that involves many organs of the body, it's been very difficult to come up with such a measure. And for most of the trials that have been done, the measures have been directed specifically at how much skin involvement specifically is there? Not skin and lung and stomach and kidney, just skin, because the skin was kind of easy to measure. Many years ago, there was something called the modified Rodnan skin score that was developed, and the physician would examine, I think it's 17 different points in the body and score the skin as being not involved to 0 and to very involved 3, and add up all the areas, right? So you'd have a total skin score, and you'd give a drug or you give a placebo, and you'd see what the skin score was before versus after, and see if there was more improvement in the skin in the drug trial and the drug versus the placebo, right?
Yes.
So that's the skin, that's the scoring, the outcome measure that was used for many years. But the regulating agencies that approve drugs for use in scleroderma haven't really been all that happy with just the skin score, because it's only one aspect of the illness.
Right.
And we've been looking for other ways of measuring this. And I am involved with a group called the Scleroderma Clinical Trials Consortium, SCTC, which represents most of the scleroderma researchers in the world. And for a time, I was president of that organization, and now I'm the executive. And that organization's goals are to help improve the efficiency of trials in scleroderma. And therefore, one of the ways of doing that is to look at different ways of measuring the disease and developing different measures of outcome, which is one of the things we've been doing. So that's really why it's important to understand the concept of outcome measures and whether they're good or not, secondary, right? You know, and that's a little bit about what we're going to be talking about at the meeting.
You know, it's really exciting work. And I think you bring up such a good point that I actually didn't myself realize, that not only are outcome measures important to track the progress of our disease, but also in terms of treatment, right? They dictate if we are seeing improvements and it's consistent and well measured using an outcome measure, then we're able to get treatment for it.
Right, right.
Wow.
Well, like, a good point. Outcome measures are not only for drug trials, you know, they're for observational studies as well, such as the ones that we've been doing in scleroderma over the last 20 years, you know. So if a patient gets worse or a patient gets better, what, for example, might predict that, aside from what treatment they've been on, you know, their genetics, their sex, their age, how long they've had the disease, etc., right? So you want outcome measures for observational studies as well as drug trials.
So may I ask, what are some challenges that perhaps your research group has experienced when creating some of these outcome measures for, as you had described, like a more complicated disease?
Yeah. Well, one of the things that we're going to concentrate on at the beginning of the talk is the fact that almost all outcome measures, whether they're just one particular concept or whether they're a global concept of multiple different parts of the body and different ways of looking at them, etc., include something called a patient global assessment or a physician global assessment. And usually they'll ask one question, like, how do you think your disease has been doing in the last month? And they'll have it scored on a scale of 0 to 100 or 0 to 10, and the patient will tick off on that scale where they think they are, okay? So those scales are called visual analog scales, where it's a straight line, or you could have a numerical rating scale where it's 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, or a scale that says, I feel great, I feel terrible, I feel so-so, I feel and in between. Those are called Likert scales. So there's different ways of doing it. And for example, in a well-accepted outcome measure in rheumatoid arthritis, there is a global scale like that that's filled out by the patients, right?
Yes.
The problem is the way those scales were developed, if you really understand what you need to do to create a good outcome measure, was basically written down, I have a feeling, by a couple of physicians having a beer after a meeting like the CRA, and said, well, what question should we ask? And how shall we word the anchors of the scale? I feel great, I feel terrible. And then boom, that became the scale used in the study, right? So when you look at how to assess scales or outcome measures, the first step is to assess something called face validity or content validity. So face validity is, well, does it look like it probably measures what it says it's doing? You know, most of those scales, I mean, you know, if you look at it, you probably say, yeah, it measures what, okay. So content validity is extremely important in developing any outcome measure. And content validity is not assessed by doing a study on that measure, et cetera. It's assessed by understanding how it was developed, all right? So as I said, if 3 doctors sat down after a meeting and came up with a scale for measuring global outcome in the patient, that has no content validity, because content validity is asking, well, what does it mean to the person who's going to be using the scale? Are the words meaningful? Is the scale meaningful? Is it measuring everything that you think should be measuring about that concept? So what is the concept even? What does global outcome mean, right? Does it include how much pain you have? Does it include how happy you are? Does it include, can you work or not? Can you take care of your household? Can you walk around the block? You know, does it include all those things? And if it does that question that you asked about how do you feel today or in the last month, is it really going to reflect all those things, right? So developing these global scales with adequate content validity means you have to do it in a certain way. You have to involve patients. You have to ask them what the meaning is of global outcome. You have to go through a whole process. In fact, that has not been done in any of the global outcome scales, not just in scleroderma, but in rheumatoid arthritis, where it's been accepted as part of an outcome measure for the for drug trials, for example. All right, wow. It's all been done in a very haphazard sort of fashion. And we reviewed all the literature on rheumatoid arthritis, psoriatic arthritis, and scleroderma, and found that was the case. Right. So one of the things that we're now working on is we've developed a working group in the Scleroderma Clinical and Trial Consortium to go ahead and develop global outcome measures the proper way, you know, involving researchers, but involving a lot of patients, because some of them are for patients, some of them are for the physicians themselves. So there's going to be 2 different parallel groups working on this, you know, how do you develop a good patient global? How do you develop a good physician global and do it properly and then use it and say, look, this now has construct validity. Okay. Well, sorry, content validity. I used the wrong word. In fact, the words are important. So content validity is something to do with how it's developed. Does it look like it was developed in a good fashion? And you can't do a study to determine if it was. You can just look at it and ask the researcher how it was developed, and you can make a decision, right? Mm-hmm. The next kind of validity that's very important is something called construct validity. So let's say you develop a questionnaire to measure anxiety, all right? So you want to know if that questionnaire has construct validity. And that means the underlying construct is anxiety, which is not something you could just pick up and look at. It's complicated, right? So you hypothesize that if you are very anxious, what else about your life or your disease would be abnormal, right? So for example, if you're really anxious, your quality of life wouldn't be very good probably, right? So you'd say, well, I hypothesize that if this is a good measure of anxiety, it will correlate well with quality of life in the patient. So the more anxious, the worse the quality of life would be, right? If you have a good measure of global abnormality in a disease like scleroderma, you'd hypothesize the same thing. Well, the worse you feel about your disease in a global scale, just a simple scale on a 10 centimeter line, right? The worse your quality of life would be. So you do a study where you'd use an accepted quality of life measure, and you'd correlate it with that global measure that you've just developed. If it correlates well, you say, well, that has construct validity, because they both would relate to how bad your underlying disease is, right? The worse underlying disease, the worse your global measurement, and the worse your quality of life would be. The problem is that without content validity of the new scale you're looking at, construct validity is really hard to measure. And the reason is this. Let's say you had a measure of depression and not anxiety. And that's what you were measuring, right? So your depression scale would also correlate well with quality of life. If you're depressed, not anxious, but depressed, your quality of life wouldn't be good. And if you looked at a correlation between a measure of depression and quality of life, you'd find out that they correlate well, just as it would if it was a measure of anxiety. So before going into that process of measuring this construct validity, you have to know that your measure is measuring depression or it's measuring anxiety. And that's where content validity comes in, right? The first step is very important. You have to know that your measure was developed to look at depression, not anxiety. You follow me?
Yes.
A little complicated, but so developing outcome measures has to really start with good content validity and then go on to measure construct validity and other types of validity.
You know, it's so interesting, right? The fact that in order to develop a good measure that is able to capture something as complex as scleroderma, we go through these processes, very rigorous processes, and these sciences of capturing face validity, capturing content validity, capturing construct validity. And I really do appreciate how well you're able to articulate that. And I think I learned something new today about all of those things. Thank you so much. And with that, can I ask, do you have any other insight you'd like to share to improve a patient's disease journey or health outcomes?
That's a tough question. We see so many patients who come in and get their information from Dr. Google.
Yes.
And that's a big problem. First of all, there's nothing wrong with looking things up on the web, and there's nothing wrong with learning about the disease yourself if you're a patient with that illness, okay? I think that's great. But look at resources that are well recognized as being unbiased and not just there to make a buck. So, like, for example, the Arthritis Society or the patient organizations that you represent, or the Arthritis Foundation in the United States, or other big organizations that put out information that's been vetted, that makes sense, that isn't just something about some strange treatment that a few people say worked, You have to understand the difference between an opinion of one or two people versus the results of a real trial. People tend to get better who are put into drug trials. Everyone, 30% of people, most drug trials get better using those outcome measures, right? So, we know that people get better with time, depending on what it is that you're looking at, right? For example, the skin in scleroderma tends to get better over time. So you can imagine that if you say, well, I gave someone a drug and their skin score that we talked about earlier gets better. Wow, that's got to be a good drug. Well, in fact, people get better without taking a drug. You want to know, do they get more better with the drug than they do just with time, right? So that's why you have to realize that the way we've developed drug trials is important. And we always compare it to placebo, for example, in good drug trials, because people on placebo also improve sometimes. That's just the course of the disease. So I think for patients, that's very important, that look for advice from good sites. Secondly, you may not agree with what your doctor has suggested, but if you don't like it, tell him. Don't go home and say, oh, I'm going to take this pill, and then he finds out 6 months later that you haven't taken it, Either you're going to have a good relationship with your physician and there's going to be some understanding back and forth, or it's going to be a one-way thing and the doctor's banging his head against the wall thinking you're taking the drug, and you come in 6 months later and he finds out that you aren't. Nobody's happy, neither the doctor nor the patient, really, in the end, So, be open with your physician and talk about your hesitancy about taking certain things and come to some resolution together, And I think support groups are important too for patients, that, you find, it's a terrible thing to find out all of a sudden that you have a chronic illness that you're going to have to deal with the rest of your life. And it's a big shock for everyone, right? And support groups have patients in them who've gone through that and can give you some feedback and help you out with understanding how it's going to be. And usually it turns out you can manage it, and help you get over that initial shock, So I think that's important also.
That's truly beautiful advice. I cannot, agree more that finding reliable information and, letting your doctor having that open dialogue and I know it's a little bit intimidating for patients to challenge, an authoritative figure at times, but these are humans and they do want to help. Believe me, rheumatologists are some of the most incredible people I've ever met. They really do want to help and they do want to listen to you and they do want to have a bond and create that therapeutic alliance. And as you said, reach out, find support. Amazing. And with that, Dr. Barron, thank you for your time. Thank you for sharing your expertise. And I wish you all of the best. I know you're continuing going to be involved in research and pushing this field forward, but I hope you take some time to yourself now that you are retired.
Thank you. Well, I'm only semi-retired. I retired from that one job, but I'm still seeing patients.
You love your work when you...
Yeah. What could I do that would be more interesting, right?
Absolutely.
Okay.
Thank you. We'll see everyone soon.
Bye-bye.